Hello, my name is Mark Fisher. I'm professor of neurology at UC Irvine and a stroke neurologist.
Hi, I'm Steve Greenberg. I'm a professor of neurology at Harvard Medical School and also a stroke neurologist.
Can patients receiving this anti-amyloid therapy, can they receive aspirin or clopidogrel or antiplatelet therapy, particularly antiplatelet monotherapy, which is an area where we have the most data? What about the patient with atrial fibrillation who would be a potential candidate for anti-amyloid therapy? And then, of course, what about the patient presenting with an acute stroke, where the patient would normally be given strong consideration for thrombolytic therapy, either TPA or tenecteplase? Does the presence or does the use of anti-amyloid therapy preclude treatment of acute ischemic stroke with thrombolytic agents? Steve, what do you think?
For now, the FDA has recommended caution in using anticoagulants. The appropriate use recommendation for lecanemab has recommended against use of lecanemab in individuals who have an indication who are taking anticoagulants. I think that is a reasonable consideration. I don't think it is reasonable to stop somebody's anticoagulant in order to be able to give them lecanemab. We don't think the benefits of the anti-amyloid immunotherapies are so great to outweigh the very well-established benefits of anticoagulation. So I think that's not a reason to stop somebody's anticoagulant. And then the third quite scary issue is use of thrombolytics. Scary in that we now have two reports of individuals who presented with stroke-like symptoms. We put an asterisk on stroke-like symptoms because we know that some can be stroke mimics, but two people who were felt to have strokes and were treated with, one case alteplase and one case tenecteplase, and had deadly multifocal intracerebral hemorrhages. And in retrospect, and based on some pathology from one of the cases, in fact, that may not have been a stroke at all, may have been ARIA-E presenting as a stroke mimic. And this has made its way into the FDA labeling for donanemab. They have a black box warning saying that high scrutiny should be given for the possibility that somebody with stroke-like symptoms, in fact, is having ARIA-E presenting as a stroke mimic, and to have great caution. My approach to patients in this situation would really be to try to establish beyond question that somebody is in fact having a stroke before even considering a thrombolytic. We know time is brain, we try to move quickly, but in this case, the extra caution is needed. I should note that there's no evidence for increased bleeding risk among people receiving mechanical thrombectomy without a thrombolytic. And I think, again, based on no good data, but based on what we know about the effects of mechanical thrombectomy, I think that should be considered a reasonable option without anything currently to point to mechanical thrombectomy being higher risk.